Hi class. This lecture will cover the more common vocal pathologies that are encountered clinically by the SLP and the different treatment options that we have to address many of these issues. We'll also cover some of the different medical treatment options that might be used for different conditions. Just as a disclaimer, copious images were downloaded freely from the internet under protection of what's called the Fair Use Doctrine, which means I can use them for free as long as I'm not charging anybody for this presentation. And many of these images are from the website of Dr. Lucian Salika, and that's www.vocalmedicine.com, and I encourage everybody to visit and browse through that website. Any treatment decisions that you will make are going to be based on information obtained during the clinical examination. Remember that all voice patients will have to be evaluated by an otolaryngologist before you begin voice therapy. So that medical examination is going to be a requirement before treatment begins. And as part of that medical evaluation, the otolaryngologist will visualize the vocal folds. Typically, they're going to use a flexible endoscope to do that, although some might also use video stroboscopy at the time of that medical examination. A comprehensive evaluation by the SLP includes a behavioral and qualitative assessment of voice and also laryngeal function studies. And if the otolaryngologist does not perform video stroboscopy and vocal fold vibratory dynamics need to be assessed, the SLP might also conduct that examination. Laryngeal video stroboscopy can be a very important part of a comprehensive voice evaluation. There are some research studies that have shown that diagnoses have changed in up to 30% of cases after video stroboscopy. The most common voice disorder that SLPs will encounter clinically is muscle tension dysphonia. And muscle tension dysphonia has two forms. Primary muscle tension dysphonia, which is defined as the presence of dysphonia or impaired vocal function in the presence of normal organic physiology and structure, in addition to normal neurological input. Primary muscle tension dysphonia is a form of muscular hyperfunction where excess motor units are recruited across the laryngeal muscles such that muscular contraction occurs with too much force, and that affects either the sound of the voice or the abilities of voice production or both. Secondary muscle tension dysphonia occurs in response to some other primary diagnosis, such as organic or a neurological etiology. Primary muscle tension dysphonia has been given other names. One is functional dysphonia, another is functional aphonia, and this is where there's a complete absence of any phonation during attempts at voice production. And as you can see in the pictures, endoscopic signs of muscle tension dysphonia include anterior to posterior laryngeal squeezing and also medial squeezing of the false vocal folds during phonation. Mutational falsetto, sometimes called puberphonia, is another form of muscle tension dysphonia that occurs typically in males who are developing through puberty, but they maintain this excess tension in the laryngeal muscles such that they don't allow their natural fundamental frequency to drop. So they speak with an abnormally high fundamental frequency. Secondary muscle tension dysphonia is very common, especially in organic disorders. And the reason for this is that it's human nature that drives us to sound normal. After all, we've lived with the sound of our normal voice for most of our lives. And when our voice becomes dysphonic, many people unconsciously strain to compensate for the impairment and produce a more normal sound, or at least an attempt to produce a more normal sound. And they can develop a muscular habit or pattern that becomes chronically hyperfunctional during voice production. And that hyperfunction can make voice quality or vocal function even more disabled than the original organic or neurological etiology, and often needs to be addressed with voice therapy. Phonotrauma results from excessive collision of the vocal fold tissue. And excessive collision occurs through talking too much, too loud, or in ways that require excessive contraction in the vocal fold muscles. each time one vocal fold collides with another during vibration, there's some damage to the vocal fold tissue. Because of this, vocal folds are continually going through a process of wound healing during and after speaking. If the vocal load becomes too great, however, the vocal fold wound healing response can become amplified, and the tissue will react in ways that can lead to the development of changes in the vocal fold tissue. Examples of these changes include vocal nodules, which are bilateral and nearly symmetrical swellings of the vocal fold cover. In their early phase, nodules begin as soft swellings at the midpoint of the membranous vocal fold. This is called the mid-membranous region. And they grow larger and stiffer as phonotrauma continues. Nodules, like other mid-membranous lesions, result in this classic hourglass closure pattern that you can see here. Vocal fold polyps are unilateral masses, and they can either be fibrous in appearance or hemorrhagic, where blood will fill the mass. And these also occur in that mid-membranous region. Sometimes polyps can be pedunculated, which means there is a small stalk that connects the polyp to the cover of the vocal fold, and that polyp can flop in and out of the glottis during phonation or during breathing. Other mid-membranous lesions that result from phonotrauma include cysts, either mucus retention cysts or epidermoid cysts. These can also occur without phonotrauma, which is why they can also fall into the organic disorder category. But the clinical reality is that most cysts occur in individuals who have heavy voice demands. Pseudocysts are polyp-like. They typically present as a unilateral, clear, fluid-filled mass at the mid-membranous vocal fold. And one theory is that these develop from hyperfunction in response to some underlying vocal fold paresis. These used to be referred to as edematous polyps, but because of this theory about there may be some underlying paresis, new theories have been developed, and these types of masses have been labeled pseudocysts in the recent literature. Phonotrauma can also cause vascular lesions. The vocal folds are supplied by very small blood vessels which run in parallel to the vocal fold tissue from front to back. And excessive collision forces can cause blood vessels to hemorrhage, as in the picture here. Repeated vascular trauma can cause blood vessels to enlarge as a result of wound healing and can appear as large vessels running along the surface of the vocal fold cover. There can also be pinpoint enlargements of blood vessels, almost like little dots, that can occur secondary to phonotrauma. And these will appear as small red dots on the vocal fold edges or the superior surface of the vocal folds and are called varices, or if there's one, it's called a varix. The reason why many lesions occur in the mid-membranous vocal fold is that this region is impacted by the greatest collision forces during phonation. If a speaker increases vocal loudness and speaks at a low pitch, they can also recruit the very posterior portion of the vocal folds into vibration. This region is known as the cartilaginous glottis. And instead of soft tissue underneath the vocal fold cover, there's hard cartilage. So speakers who chronically talk loud and at low pitches can be at risk for developing vocal process granulomas, which occur or appear as fibrous swellings at the vocal process of the arytenoids. Although there are also organic causes for granulomas, because phonotrauma can cause these, they also fall into the category of function disorders. The common physiological impairment underlying functional voice disorders is a muscular imbalance between the subsystems of speech production, that is, respiration, phonation, and resonance. And this imbalance is caused by muscular hyperfunction. Because of this, most functional voice disorders will respond to a common treatment target, namely, restoring the physiological balance between these three subsystems. And we have a number of different options for treating these. And we've covered a number of these already in class. Vocal function exercises, resonant voice therapy, stretch and flow voice therapy, circumlaryngeal techniques such as massage or laryngeal reposturing, semi-occluded vocal tract exercises. There are a number of other techniques that might be attempted. Facilitative approaches have been described in detail by Boone and colleagues, and also the use of what's called the confidential voice, which is a pattern of low volume, soft phonation that reduces the collision forces experienced by the vocal folds during phonation. Now, a common theme in the treatment for functional voice disorders is that patients are taught to change their muscular patterns during voice production. In some way, all treatment approaches for functional voice disorders teach the patient to breathe more efficiently, slow down their rate of speech, speak in a relaxed manner without excessive muscular effort, reduce the amount of talking if possible, and speak with less volume so that vocal fold tissue has a chance to heal or is not subjected to large amounts of phonotrauma. So really, regardless of what specific intervention technique you're using for functional voice disorders, all of them are really incorporating these concepts as part of their therapy plan. So let's talk about organic voice disorders now. Remember that organic disorders result from some organic change to the vocal fold tissue due either to a systemic condition or external forces, which occur regardless of whether the patient used their voice or not. So theoretically, organic disorders can occur even if the individual doesn't talk. Treatment for organic disorders can be drastically different than treatment for functional and neurological disorders, and this is why accurate diagnosis is crucial. So laryngeal cancer is a type of organic disorder, and this can occur at the level of the glottis. It can occur in the supraglottic laryngeal regions or in the subglottal regions. And its appearance can take on many forms, but often it presents as a white or whitish irregular mass growing out from the surface of the vocal folds. It can invade deep into the vocal fold tissue, and when that happens, it can significantly stiffen the vocal folds and cause a hoarse voice, which is the symptom that often causes the patient with glottal cancer to go to the doctor. Precancerous dysplasia or abnormal tissue growth can look very similar to cancer, although the cells that make up these lesions are not yet cancerous. Cancer and other dysplasias will often undergo surgical biopsy to test for cancer cells. If the laryngeal cancer is confirmed, the medical treatment will depend on a number of factors. It'll consist of one or more options that include surgery, radiation, or chemotherapy. Presbylaryngis is the medical name for vocal aging. As we age, the vocal fold tissue will change. Although changes at the molecular level can be somewhat different for males and females, often there's a loss of muscle fiber size and possibly muscle tone. These changes can cause the vocal fold bulk to atrophy and take on a curved or bowed appearance when abducted, such as in this picture here. Often this causes the vocal process to be very prominent, and you can see in this picture the vocal processes seem to be sticking out towards midline. They're really not. It's because the membranous vocal fold has atrophied and thinned out. When closed, the vocal folds that are bowed will result in an elliptical or slit closure pattern, as you can see in this bottom image. There are a number of treatment options that exist for presbylaryngis. The goal in all is to correct the glottal insufficiency. Injection laryngoplasty can accomplish this with immediate improvement in voice quality and vocal function. However, to date, all injection materials that are used for injection laryngoplasty are temporary, with the effects lasting from a few months up to a year. Behavioral voice therapy targets reduced muscular function or hypofunction. To correct the glottal insufficiency, the muscles of the vocal folds will need to be overloaded and fatigued regularly to promote muscle adaptation. Evidence-based treatments which can accomplish this include modified vocal function exercises, as we talked about in class, the Lee Silverman voice treatment, phonation resistance training, and also expiratory muscle strength training. It's also possible to permanently correct glottal insufficiency with laryngeal framework surgery, although this might be the last option due to the permanent changes in laryngeal structure that surgery is going to create. I mentioned previously that vocal process granulomas can have functional causes. They can also result from organic causes, including chronic laryngopharyngeal reflux, and also injury from endotracheal intubation during surgery. Granulomas can range from very small to very large and are typically unilateral, but can occur bilaterally. Granulomas may or may not cause dysphonia depending on their size and the degree to which they extend into the membranous glottis. Patients often report a globus sensation or pain in the throat when swallowing when they have these granulomas. The most effective treatments are a combination of time, medication to control possible reflux, and also voice therapy to target any hyperfunction so that when the individual speaks, there's minimal collision that occurs at that cartilaginous glottis during phonation. Vocal process granulomas can take a long time to heal, upwards of 6 months or more in many cases. Surgery has and continues to be performed to remove granulomas, but the fact is they tend to reoccur after surgery because of the wound healing process. Surgery is really a better second option to be used in cases of granulomas that just won't seem to go away. Vocal fold cysts are also included in the functional disorder category, and that's because patients who develop cysts also tend to experience heavy vocal demands, either from work or social interactions. And cysts tend to occur in that mid-membranous region where other functionally related masses will occur as well. Theories for organic cyst formation include blockages of mucus glands within the vocal folds in cases of mucus retention cysts, and also dead epithelial cells that become trapped in the vocal fold layers during the process of normal cell turnover. Normally, those dead epithelial cells would shed off and you'd swallow them or expel them out. One theory for cysts is that some of these cells get trapped underneath the surface of the vocal folds and turn into a cyst. Cysts don't tend to respond to voice therapy as well as vocal nodules do, and frontline treatment often involves phonosurgery to remove the cyst from the vocal fold cover. Voice therapy is often a treatment that's included in the management plan, however, and its aim is to reduce any compensatory hyperfunction that can accompany cysts and to prevent any phonotraumatic behaviors that might have contributed to the cyst formation. Laryngeal papilloma is caused by the human papillomavirus. These lesions appear as clusters of wart-like translucent growths on the surface of the vocal folds. They can occur anywhere along the length of the folds, and when they invade the membranous glottis, they can cause hoarseness. Papilloma can be difficult to manage. Surgery for removal is really the frontline option. The surgical approach will vary depending on the otolaryngologist, with some favoring cold instrument extraction and some favoring laser removal. Papilloma has a tendency to grow back often, and many patients have to go in for regular surgical removal. Some surgeons may also inject the antiviral drug Cytofovir directly into the vocal folds at the time of surgery, although the effectiveness of that treatment for laryngeal papilloma is still somewhat debatable. Scar tissue that forms on the vocal folds is most often related to prior phonosurgery, such as surgeries to remove nodules, polyps, cysts, or other masses that can form on the vocal fold tissue. Scar tissue is fibrotic and stiff, and because this tissue influences the vibratory dynamics of the vocal folds, scar is best observed with video stroboscopy. Many times video stroboscopy is required to differentially diagnose scar from other lesions. Treatment for scar is incredibly difficult, and as of today, there really is no cure once scar tissue forms on the vocal folds. However, a number of talented clinical scientists are working right now on solutions for treating scar, so hopefully in the near future we'll have some solutions. There are some surgical options for attempting to reverse the effects of scar, although they're all really experimental right now, and none have shown consistent benefits or a significant impact on vocal function in a majority of patients. And one additional risk of surgery for vocal fold scar is that surgery itself presents the possibility of new scar tissue forming on the vocal folds. Rinke's edema is characterized by chronic swelling in the superficial lamina propria of the vocal fold tissue. In many patients, this swelling is extreme, and the fluid within the vocal folds is thick and gooey and viscous. Rinke's edema is most often seen in people who are chronic smokers, especially females. The thick gelatinous material in the vocal folds also produces a characteristic voice quality that sounds very deep in pitch and very harsh. Treatment recommendations typically include the cessation of smoking. Surgery can be performed to remove the excessive fluid in the vocal folds, but many laryngologists will require a patient to commit to smoking cessation before they operate. And it is true that even after surgery, the Rinke's edema can recur. Laryngitis is a common condition, as all of you will know, and it's characterized by inflammation of the vocal fold tissue and surrounding laryngeal region. Endoscopically, it's characterized by swollen vocal folds with inflammation signaled by prominent vasculature along the vocal fold cover. Increased mucus is also commonly present, as you can see in this picture. Laryngitis is most often acute, with symptoms lasting approximately a week. It can be chronic, however, either due to repeated bouts of laryngitis or symptoms that start and never really fully reside. Laryngitis can be caused by viral infections or it can be caused by bacterial infections. Typically, in viral infections, treatment centers around pharmaceutical control of upper respiratory secretions in addition to vocal hygiene. In bacterial infections, an antibiotic might be prescribed. A sulcus is a ridge or furrow that appears as a depression in the vocal fold cover. There is some debate as to what causes sulcus vocalis. Some theories suggest it is a lack of maturation in the vocal fold tissue during the significant developmental period around puberty. Other theories suggest that it can be caused by trauma to the vocal fold tissue, such as poor wound healing secondary to surgery or rupturing of blood vessels or other lesions within the vocal fold tissue. Treatment typically consists of phonosurgery, although the prognosis for significant recovery is debated. Surgical approaches include implantable materials such as fat or other substances that can be applied via injection laryngoplasty. Laryngeal webs are bridges of tissue that connect the left and right vocal folds. They can be congenital or they can be acquired, typically the result of either intubation or prior phonosurgery. Webs occur most commonly at the anterior commissure of the vocal folds, although they can occur posteriorly too. Small anterior webs will have little effect on vocal function, although larger webs can be so severe that they even affect breathing. Treatment for webs can be challenging because it's difficult to keep the corrected tissue on one side from touching the other side during healing. Phonosurgical procedures include open laryngeal fissure, where they go in and cut through the larynx itself to split the web, with the placement of a celastic keel or cover to protect the repaired vocal fold edges. Other techniques that involve microlaryngoscopy to resect the web are also used. Neurological voice disorders are caused by a disruption to the nerve supply for the muscles of the vocal folds. This can result from an acquired injury secondary to surgery, or can be related to a degenerative neurological condition. The most common neurological voice disorder that will be encountered clinically is vocal fold paralysis, and of the types of vocal fold paralysis, the most common presentation is unilateral vocal fold paralysis. Unilateral vocal fold paralysis results in glottal incompetency due to one vocal fold being unable to approximate to the midline. Perceptually, the voice will be breathy, and the patient will have difficulty generating significant loudness. The position of the paralyzed vocal fold can be prognostic for recovery. Large glottal gaps have a worse prognosis than small gaps, and large gaps will often need more permanent surgical solutions to improve the voice. Injection laryngoplasty is a good first-line treatment for unilateral vocal fold paralysis because it can make an immediate impact on vocal function. It can be performed on an outpatient basis, and it's also temporary, so spontaneous recovery is likely to occur. The injection material will not impede that. For small glottal gaps, voice therapy approaches for hypofunction can also be effective, and it would be wise to combine these with injection laryngoplasty if that's possible. For larger gaps or paralysis that does not recover, laryngeal framework surgery using different implants or repositioning the effective arytenoids towards the midline may be the best option. Spasmodic dysphonia is a form of focal laryngeal dystonia. The most common type is adductor spasmodic dysphonia, where the adductor muscles experience unpredictable dystonic contractions during phonation. The voice of adductor spasmodic dysphonia is often perceptually characterized as strained and strangled with intermittent voice stoppages. And it's not going to be able to play on this, but you'll have the audio on your PowerPoint slides. In abductor spasmodic dysphonia, the posterior cricoarytenoid contracts involuntarily to compete with the adductor muscles during phonation. The voice quality of adductor spasmodic dysphonia is intermittently breathy and weak voice with voice stoppages. There is no cure for spasmodic dysphonia, and the current first-line treatment is injections of botulinum toxin into the laryngeal muscles. The voice problems of patients with spasmodic dysphonia can often be exacerbated, however, by compensatory hyperfunction, which voice therapy can address. However, voice therapy is not effective for eliminating the dystonic contractions that are caused by the neurological disorder. And some research has found that voice therapy, after injections of botulinum toxin, can have a significant clinical effect on voice quality and vocal function in patients with spasmodic dysphonia. Vocal tremor can occur as an isolated laryngeal tremor, or can be part of a larger condition affecting the head and neck and limbs. It's characterized by a perceptual rhythmic tremor in the voice, which affected patients will often describe as shaky or wobbly. Some pharmaceutical treatments that are taken as oral medication are beneficial for a minority of patients. Other pharmaceutical treatments include injections of botulinum toxin, for which patients have found temporary relief from tremors, although Botox, like oral medications, are not effective for many people. Like spasmodic dysphonia, voice therapy can be beneficial for relieving compensatory hyperfunction, although again, it doesn't target the neurological cause of the tremor. Idiopathic voice disorders have no known cause and include vocal cord dysfunction, which is also known as paradoxical vocal fold motion, and chronic cough. Vocal cord dysfunction is characterized by involuntary adduction of the vocal folds during inspiration when they're supposed to abduct to allow air into the lower airway. Vocal cord dysfunction is triggered by a number of factors, including physical exertion, allergies, and noxious odors, among other things. Patients are often misdiagnosed with asthma and present to the clinic with a history of other medical diagnoses and prescriptions, none of which have presented reliable relief from the condition. Vocal cord dysfunction is difficult to elicit in the clinic. During endoscopy, the patient may or may not experience an episode. Diagnosis is most often made based on history and presenting symptoms reported by the patient, along with confirmation of normal aerodynamic physiology and vocal function. Voice therapy can be very effective for this condition. Exercises that focus on breath control seem to work well for many patients. Open throat breathing techniques, slow inhalation through the nose, and exhaling through pursed lips are strategies that can work well to manage attacks. Quickly sniffing through the nose and exhaling through pursed lips is another strategy which can help pull a patient out of an attack. Patients will also benefit from sensory awareness activities that help them identify triggers for attacks and also the body sensations that precede the initial period before the attacks. Chronic cough is exactly that, frequent coughing which will not subside even after various medical treatments. Treatment with voice therapy can be very effective for a compliant patient. Effective programs of therapy for chronic cough include educational components combined with vocal hygiene and cough suppression strategies. Suppression strategies that have found to be effective include using an effortful swallow when preceding the onset of cough, breathing or panting through pursed lips, and using a dry or wet swallow to suppress that urge to cough. Some physicians may also recommend prescription-strength cough suppressants, although there has been long debate about the actual effectiveness in suppressing cough with these medications. They seem to work for some patients, but for many, they do not. So I'd like to thank you for your time, and glad that you had an opportunity to hear this lecture, and I look forward to seeing you in class where we can follow up. Have a good one.